week, Surfing the MASH Tsunami brings you 3 major stories from the world of steatotic liver disease. This weekend, we're bringing you each of these stories separately so you can listen over a shorter, discrete period of time. Hope you enjoy them.
For the last 5 years, MASLD stakeholders, whether manufacturers, trial sites, providers, payers, patients, or investors, have turned to surfing the MASH tsunami to keep track of drug and device development, epidemiology, public health initiatives, and practice patterns. This weekend, we are sharing the 3 main sections from our episode 11. Roger will provide more information after these notes from our sponsors.
Surfing the MASH Tsunami is sponsored by these healthcare-related organizations.
Regeneron is a leading biotechnology company that invents, develops, and commercializes life-transforming medicines for serious diseases. Founded and led by physician scientists, their unique ability to repeatedly translate science into medicine has led to numerous approved treatments and product candidates in development, most of which were homegrown in their laboratories. They are shaping the next frontier of medicine with data-powered insights from the Regeneron Genetics Center and pioneering genetic medicine platforms, enabling them to identify innovative targets and complementary approaches to potentially treat diseases like obesity and MASH.
LiverRight and the LiverRight Scanning Network. LiverRight is America's first virtual specialty clinic for liver disease, offering adults in all 50 states video appointments and helping GI practices and health systems triage and treat the swelling numbers of patients seeking MASLD and MASH testing. LiverRight offers same-week video visits and accepts insurance. For more information, contact LiverRight. That's liver then R-I-G-H-T as if one word, at www.liverright.com.
Tawazun Health, your partner in global liver health innovation. At Tawazun Health, we specialize in providing small or large-scale access to FibroScan examinations for liver health-focused early detection, clinical trials, independent research, and collaborative projects with clinicians and FibroScan providers, now in over 30 countries around the globe. As industry-leading experts, we design and deliver high-quality FibroScan services because we know that accurate, high-quality, reliable data drives better outcomes. To learn about Tawazun Health or our sister lifestyle app, mylife365.me, click the Tawazun Health link on the Surfing MASH homepage. This week starts with the first half of our Multi-Metabolic Week Roundtable, moderated by Louise Campbell and including Dr. Karen Jerome-Zapadka of Trajectory Health Partners in the U.S., and Dr. Alfonso Lopez-Alba and Irene Lopez, both from the EDOM clinic in Spain.
The core of this episode starts during the weekly groundbreaker exercise. Our guests begin to describe the paths that brought them from single disease specialization to multi-metabolic practice. After that, they describe their clinics today, including the patient population and principles underlying their approach to treatment. For Dr. Jerome Zapadka, the path goes from a conventional gastroenterology practice to an obesity practice to a multi-metabolic practice. For Dr. Lopez, he starts with, as he puts it, re-educating the hypothalamic problem, and that led him to focus more broadly over time on issues related to multi-metabolic disease. From there, the discussion goes on to talk about the diagnostic tests that people use in the different clinics, largely FIB4 and FibroScan, some use of ELF, but not as much, and then approaches to treatment with the availability in the U.S. of Rezdiffra and in the EU of GLP-1s, even though not necessarily for MASH at this time.
Okay, so we're going to ask each of you just to introduce yourselves and tell us a bit about yourselves. Tell us where you sit within the field, and I'll start with Karen for that. And then we want to know one single thing that most of your friends and family might not know so much about, or work colleagues. And we've had Jeff Lazarus running with the Bulls in Pamplona. We've had Nigel Ferguson wearing gold lame shorts as a Take That tribute. We've had all sorts of stuff, I assure you. To Alina Allen playing music and folk music and things like that. So we get the weird and wacky out of everybody. So give us one back. But let's start with Karen. Karen, tell us a bit about yourself and where you sit within the space of multi-metabolic clinics.
Thank you for having me. I'm very happy to be here. So I am a community physician practicing in the community. Started out as a gastroenterologist from the University of Pittsburgh. I did all of my training there and started out as a gastroenterologist. And it wasn't long before I began to see, the devastations of the obesity epidemic with multiple cancers, and then turning from hepatitis C and treating that well to coming into this steatotic liver disease epidemic. It hit me to the point that I realized that I needed to have more training. So I went back about a decade ago and got my board certification in obesity medicine. Was one of the first physicians in the Pittsburgh area and the Beaver County area where I am outside of Pittsburgh to get that certification. And along the way, I was exposed to a number of other medical organizations, one of which was an organization called Low Carb USA, now the Society of Metabolic Health Practitioners. I went to their first conference in 2019, really began to understand insulin resistance and metabolic syndrome. And from there, my practice dramatically changed. And I began to practice in the community, primarily with fatty liver patients, metabolic syndrome patients, pre-diabetics, diabetics. And the focus now is clearly on disease reversal, drug de-escalation. We totally changed how our obesity practice was teaching patients. We now are in a new practice where we're implementing health coaching, which is so important. We have a fitness instructor with us, a nurse practitioner, and so it is a much more comprehensive type of setting for the patients, but it is strictly around low carb and very low carb approaches to these patients that have metabolic syndrome and insulin resistance. And we're seeing phenomenal results now, and we can talk about that.
That's wonderful. And one little fact that we might not know about you.
Well, I shared this with some people, and so I myself had insulin resistance about a decade ago and understood this from my training that I was getting and totally turned it around, and I'm fine today and actually very healthy. But I had to struggle with the fact that I am a very good baker, and I am the holder of family recipes, pierogi from our Polish side and ravioli from our Italian side, and these are huge traditions and recipes passed down for generations. And we also have a wedding coming up, and we do something called the Pittsburgh Cookie Table, where we have all the friends and family baking cookies, as well as myself. I'll probably bake at least 15 kinds. So we'll have over 170 dozen cookies at the wedding, probably 50 different types of cookies. So it's a huge tradition in our area. And of course, it's a very special. We only do it every so often now. I don't bake like I used to, but I still try to hold on to all the family recipes that have been literally handed down for generations.
I do not envy your task or the gene pool from both sides of that family when we're sitting here talking about insulin resistance. And
exactly. So yes, we have come to grips with that.
Thank you for that. That was really interesting. And Dr. Lopez Alba, thank you for joining us from Spain.
In the north of Spain, the studies in the north of Spain, Gijón, in the north of Spain.
And you are an endocrinologist by background, aren't you? And you run a multi-metabolic clinic. And I think that's why this episode is so exciting, bringing extra or additional speciality to liver disease, and we're the smaller part of the metabolic syndrome part. So tell us about the clinic, tell us about you, and you've got a colleague with you if you introduce her, and that would be useful.
Yeah, I'm Irene Lopez, and I will also be kind of the translator and the data analyst of all of the clinic, and I will be speaking in English. And well, the clinic, first of all, was formed in 2022. And it was just a project started only by him, because all of his life trajectory, ever since he graduated, he specialized in endocrinology, and he went to many congresses all around the world, United States, went all over Europe to know more and more about endocrinology, specializing in diabetes and also focusing on thyroid. We could say diabetic people and metabolism and all of these issues. And yeah, the clinic was formed 3 years ago, and it's at the very north of Spain, as he said. and everything's going quite well. There are not many clinics like the one that is here because we count with a lot of instruments that not many clinics have. We even made a kind of a small presentation that we could show with the instruments that we have to assess patients and everything. And we have the FibroScan, which is one of the tools that we have implemented in March 2025. And so far, we've done 182 FibroScans on people and have 462 people with tirzepatide, sorry. And we are experimenting with these new medications that are coming out, which are completely a revolution for us. And he's dedicated his whole life to finding how to help people with obesity, as it is a really important disease that is sometimes overlooked and even stigmatized. And yeah, we could say that.
And that's wonderful. That's really exciting. And I think that's one of the reasons that we wanted a different field, because we speak to hepatologists and people within the MASLD and MASH field an awful lot, as you'd expect. So it's nice to bring new people into the speciality, but it's nice to see that other specialities are becoming aware of the liver beneath. So one fact about Dr. Lopez Alba he's prepared to share about that most people wouldn't know.
Algo que quieras decir que no mucha gente sabría.
The liver is really the...
No, pero algo sobre ti.
About me.
About him, yeah.
30 years of work in the endocrinology.
What I can say about him is that when he was young, he used to dance very well. Yeah, that's something I know. I was told.
Wonderful. What I'm going to do is walk around everybody and again, just ask for one professional, one personal good thing that's happened to you guys in the last week or so. And it can be anybody. Let's start with Karen again. So Dr. Lopez has time to think.
I think professionally, just being invited onto this podcast was an honor. I'm very happy to be here. Also professionally, just seeing our patients back. We had a wonderful week this week in our center. We saw a patient back that is just doing phenomenally. And I could go over the statistics of this patient later if you want to get into the details. But just seeing patients come in with severe fatty liver, pre-diabetes, hypertriglyceridemia, and just with nutrition and lifestyle alone, reverse everything, have significant weight loss and improvement of all the metabolic parameters. Blood work is really, really gratifying. It's why we, continue to do this. It's just amazing the results that you can see if they follow the program that you set out for them.
Wonderful. Thank you. And your team, any good professional or personal things that have happened in the last week for you?
For us, we just absolutely 30 minutes ago, we saw a patient. When she first came, she was 15 years, 15. She was 15. And she came into the clinic with a weight of 132 kilograms. She also had a mental illness. It was very difficult for her to encourage her to lose weight. She was suffering a lot, both mentally and physically. And in 9 months, she came to 83 kilograms. We just saw her, and that was absolutely amazing. It's amazing how these medications that are coming out can change people's lives and their quality of life. And it's just so amazing to see people smile again, walk again. Like this girl had many mental issues. She kept up also with psychiatry and psychological assessment. And it's just amazing. And we believe that that's what it makes also. He's told me that that's what makes him happy, seeing people regain their independence and their happiness, because after all, obesity limits you as a person sometimes, and it's also very bad for your mental state, and it should not be stigmatized, as we said before, and that's what makes us happy mostly. Because it's a problem and it's not their fault, and we are thankful that there are many medications coming out to help them, because it's really serious and important to treat.
I think that's important. And I think, my highlight of the week, I'm going to continue on the same theme because I was doing a clinic the other day and I specialize in FibroScan and the delivery of FibroScan and direct to areas like endocrinology who don't have the liver background and don't want to utilize their staff to do that. So we bring in the field staff to do the fibre scans, talk about liver health, talk a little bit about nutrition and the wins for liver health out of the whole comorbid situation, rather than actually just focus on the liver and not anything else. So we appreciate the FibroScan is a toy, a leading non-invasive diagnostic, along with any liver stiffness measurement device that we can deploy, but it's been traditionally seen as only a hepatology assessment. And I think that's where the background is. And obviously for us now, it's diversified into a metabolic assessment of somebody's risk of diseases of cardiac, endocrine, chronic kidney, and the whole portfolio. So this week I saw a lady who, after I was discussing her FibroScan, she burst out into tears and she apologized. And I said, "Why are you crying?" And she said, "Because you didn't tell me it was just because I ate too much." And that whole thing about we assume that they have fatty liver because they eat too much. But she was a very resilient lady. She'd given up alcohol a long time ago. She'd then given up smoking. And some of the other issues that help you give up there, you tend to nibble, you tend to do different things. But she said, "I'm just emotional because I'm so happy that you didn't use that language." And I think that to me strikes home is that we need to be inclusive. I only get to see the liver. No matter what the shape is on the outside, it's the liver that tells me the story. So that was my positive for the week, because they were happy tears but relieved tears in this lady. So I totally share the background that you've just said about your wins for the week, and way to go for everybody. One of the reasons I wanted to focus very much on this particular topic and the sort of multi-metabolic clinics is that we're starting to discuss it a lot more in hepatology. And I worked at Imperial, for example, and we had a joint liver endocrine clinic. It was only once a week. It was for a small number of diabetic patients that a couple of endocrinologists would refer. It wasn't for the whole clinic. So although we're tipping in there, what we need is more of this endocrine asking hepatology, or using hepatology assessments to now look at the steatosis. So both of you run innovative clinics within your regions with psychiatrists, nutrition, and things like that. So, Karen, tell us about how that came about and how you sort of broke out of the hepatology, or you brought the hepatology side in, which probably accumulate to 1/6 or 20% of the patients that you actually probably do see may have advanced liver disease or poor liver health.
Yes, so I practiced for many years in a GI center, and we did see a lot of steatotic liver disease and other liver disease as well. But it became clear that when you really look at patients with MASLD, they have insulin resistance and metabolic syndrome. That is a systemic disease. So you really have to become comfortable with looking at every part of the patient to understand that to treat their liver, you have to treat everything about them. And so once you have a firm grasp on insulin resistance and metabolic syndrome and the risks for a multitude of every organ being involved, you begin to treat them more. I feel like I'm a much better internist now than I was during my internal medicine residency, because I understand now that by treating the insulin resistance and the metabolic syndrome, you are going to improve every organ system. And so each patient that I see, and I focus on the insulin resistance and metabolic syndrome, we ask them, is your goal to manage this or to reverse this? And so the answer is almost always, I want to reverse this. I don't want to need multiple medications. I want to reverse this before that need comes into play. And so by looking at their nutrition, their physical activity, their behavior, and all of their medical issues, you can really set them on a plan that is going to get them to reverse all of that before they need medication, or if they're even diabetic or pre-diabetic and on different medications. the whole role of drug de-escalation, saying we can improve this to the point that we can begin to remove some of these medications. And we're already doing that. So our goal is, rather than looking at these diseases as chronic and progressive, we go in right from the start and say, this can be reversed with the right lifestyle. In my practice, it's all some element of therapeutic carbohydrate reduction, whether it's low carb or very low carb, getting into the ketogenic range, really depends upon the patient and their level of insulin resistance. And we make that decision together. But we have not seen one patient with insulin resistance and metabolic syndrome that has not improved with this type of program.
That's fantastic. And I think it's really reassuring for people to listen to that.
For sure, even patients with severe steatosis, if they don't have advanced fibrosis, just with improvement in the nutrition and some weight loss, they can improve their fatty liver and reverse it. I mean, and I work out of two centers, my new center that I've opened on my own and my GI practice. And we're well over, many patients with complete reversal. We use FibroScan. In my old practice, I have a Velicur scan now that I'm using. So, being able to measure that by the scans and see complete reversal, improvements, reversal of type 2 diabetes we're seeing very clearly, certainly reversal of prediabetes, hypertriglyceridemia, all of that's very, very gratifying. But you present the patient with the option, do you want to reverse this? That should be their first option.
Fantastic. Now I'm going to ask Dr. Lopez Alba to share your experiences of this, again within endocrinology and utilizing toys. I always use the word toys because the patients appreciate it. Little, very world expensive leading diagnostic toys like FibroScan and obviously Velicur, as Karen's described. How do you find it? How do you engage the patients? How does it work within your particular clinic?
¿Cómo reaccionan tus pacientes ante todo esto del FibroScan?
Se sirve mucho de mucha motivación. This is a issue of motivation for the patients. They see really the degree of fatty in the liver, and it is very, very, very impressive for them, because they say, I have so much fat in my liver, and this is they can see the real problem. And I am not really totally agree with the only food assessment for hepatic problems. I think that these are more complex, much more complex, with the integrate of hormone issues, and we have not ever the solution of this problem. And we have the gold la bala de plata. La bala de plata.
No se puede decir así.
Vale, nosotros tenemos the gold.
Our goal
yes.
is to what?
Yeah.
¿Para qué?
For re-education the hypothalamic problem that drive the obesity. And the obesity is la locomotora,
it's driven by the hypothalamus.
The hypothalamus, and we have diabetes, we have problems, insulin resistance, and problems in cardiac problems, ictus.
Everything
of the problems. We have only two causes of death. One is the insulin resistance and the cardiovascular problems, and the cancer with short telomere. That is the autodestruction button in our life. And we are programmed to the death. But we have to get quality of life as long as possible. And with these drugs, we can obtain this important goal.
So can I ask you both, within your clinics, by the addition of liver non-invasive diagnostics, do you use FIB4, do you use the ELF test, or do you just go for FibroScan to detect steatotic liver disease? And how has that helped your practice, particularly within endocrinology? Because it's not a normal device that's used within endocrinology around the world.
We explain to the patient that the liver is the fabric of the body, and we need a hepatic health for recover our own health.
But regarding the question, we only use FibroScan. We don't use any further tests. We are mainly focused on the results that we can show them in the numbers, and we don't have any additional tests so far. We have not added anything else. We have the ultrasound, the in-body count to check the index, the body composition. We don't have further instruments yet, but regarding FibroScan and regarding the health of the liver, we only have that, the FibroScan.
And Karen, what about yourself?
In my GI practice, we've had a FibroScan machine almost a decade. We were one of the first in our community area near the Pittsburgh area to have this technology. And it was game changing. When patients could see that report and understand the level of steatosis in their liver, that was one of the first things that I had ever had in my practice that motivated patients to change when they could actually see that report. So that was a game changer for us. So now we have the Velliker scan at my new practice, also an amazing technology. I love it because you can actually visualize the liver. You know that you are over the liver and your area of interest is over that liver tissue to obtain that fibrosis score. So I'm using both. I'm very comfortable using both. We calculate FIB4 scores on everyone. If there's any type of discrepancy, we're getting ELF scores very, very frequently. I've ordered MR elastography very frequently. And the patients understand that these are all just non-invasive methods to get at that level of fibrosis. And now, to truly understand, are they a candidate for the new, for Rezdiffra? And we do have a number of patients on that medication. So we're comfortable using these technologies. The patients understand why we're ordering them, what's at stake, do they need this medication? And then also on the flip side, when the patients see that these scans are improving, it is so empowering for the patient to see that what they are doing the task of the nutrition, the physical activity, the sleep, the stress management, and to see that all comes together and culminates in a scan in 6 months that looks so much better. That is so empowering to them. It really is motivating to keep them going.
From my perspective as a nurse consultant in that area, and particularly developing FibroScan out to everywhere rather than just in hepatology, I think it's reassuring for me to know that that's exactly the way that when it's introduced, or endocrinologists choose to have it, that it empowers their practice. If you suddenly took it away and all you had was the previous, do you think that's a better standard of care or a worse? Because some people say, I don't need it, or I don't need to know the steatotic disease. Having had the light bulb moment where you can actually visualize and see the liver in a better context, what would it mean to actually just take it away?
Devastation. I'm not sure I could function without it.
No. Dr. Alba, how would that make a difference to your practice if we suddenly took it away? This visualization of what the liver looks like, or better information on the liver health, I suppose.
Well, regarding the FibroScan, we've only had it for 5 months. And around 80% of the patients, we offer it to them and they say yes, and the other 20% reject it. Because there is also an issue in Spain regarding being able to afford to do this. It's very expensive because the salaries in Spain are quite low compared to what the real price of this is. So some patients are like, no, I don't need to know this specific thing. I only want to know what's my weight, what I can do. But they are little. They are not as many patients, and many of them accept. And not many clinics specialize in this. But we believe that it is a test that is gaining more and more importance, and that it determines a lot of things because we consider the liver being one of the main organs for the hormones. It is very important, and patients do reject it, but it's a small quantity compared to the ones that do not reject it. And it's good that people are also caring about their hepatic health because, as Karen said, it's really encouraging when people can see that they don't have their previous liver to what we've told them to do, and how they see it with proof. And yeah, it's very encouraging.
And do you think it enhances your ability to care and provide pathways for those patients? And the non-invasiveness of it obviously is attractive to patients. Do you think it's actually really enhanced your practice in the field of obesity management? Particularly, you treat a lot of patients with Mounjaro, don't you? So that is not yet approved in fatty liver, is obviously, and MASLD and MASH, because it is going through the trials, but it is looking outstanding in what it's delivering, let's say. So the likelihood of approval we expect is going to be high. So you're using FibroScan in the normal weight loss area. And now I've said on the podcast multiple times that we're missing the data by not using FibroScan in weight loss management for semaglutide and things like that. You're gathering that data. What are you sort of seeing in the real world of people using Mounjaro with non-invasive technologies like this?
So far, we've seen really high improvement with Mounjaro. It is changing. The ad of the GLP-1 and GIP, it's changing completely. We believe that it's a better alternative than Ozempic, but it depends on the cases also. And it is amazing, honestly. Yes, honestly, in real life, I think that it has demonstrated its improvement and people are happy with it. But also, again, one of the bad things about Mounjaro is affordability. And there is a 10 to 20% of weight decrease, weight loss due to this medication. And we can achieve that in the 90% of the patients. And it's giving really good results. However, we are still seeing the data of how it combines with FibroScan. We are still studying it because we've only had it for 5 months. So what we aim to do is when we reach a year, it's combining both FibroScan and Mounjaro. And once it reaches a year, we will see how the liver has changed due to the treatment and the correlation with bioimpedance. And yeah, so that is it so far.
Wonderful. Karen, you've already said that you use Rezdiffra. Yes. So what are you seeing now in the FDA approved medication and how you're able to monitor and in the real world?
Well, again, the patients that we have on it are in my old GI practice. We have a few patients in our new practice with the Velicur that may be candidates. But my first patient on Rezdiffra did phenomenally. I mean, her FibroScan went from severe steatosis to zero steatosis. And she went from F3 fibrosis to F1 fibrosis at her 6-month FibroScan. So that was an incredible success with the medication. So I think we'll see. I'm just getting experience with it now. I don't have very many patients on it, but we do have a few. And certainly my first one did very well. I did want to go back to make 2 other points. The body composition analysis that you're using, I'm using it as well. That is another tool that I think is we could not function without, because when the patients come in, it's really telling us not just that they have weight loss, but what is that weight loss? Is it fat mass? Is it muscle mass? And it also gives an assessment of visceral fat. And so you can, again, use this information. If a patient, particularly, I don't use GLP-1s a lot. I mean, we are seeing drug-like effects from ketogenic diets getting just as much weight loss as medications in a lot of our patients. But I do have some that are struggling, and we do use the medications, but we don't have to use them that often. But that tool has been invaluable to show the patient if they are not doing resistance training, getting adequate protein, particularly if they're on a GLP-1, their weight loss can be a significant amount of muscle mass. And so that really is their wake-up call to really pour themselves into the resistance training, make sure they're getting adequate protein, and then you can follow that. We follow that every 3 months to make sure that their weight loss is appropriate weight loss.
And I think what you described there is what I feel the strengths of endocrinology or cardiology is, but probably more endocrinology, is you have other assessment devices. The muscle mass, we don't use those particularly in hepatology. And I think we look for the liver specific, and we're very, very focused on just one particular point. And I think what you two are describing within your clinics is this whole person-centered approach where you look at the person and you treat holistically with the other support mechanisms, psychiatry, nutrition, appropriate assessment, non-invasive diagnostics, and where the skill sets are to assist that person. Now, my understanding of where we're moving to multi-metabolic clinics is that can be really cost efficient for hospital and services, that we don't all have a dietitian. We don't all fight for the same pot of money. We don't be combative, which you can often see in different healthcare systems, but combining our resources releases resources. So I always see that as a potential benefit of multi-metabolic clinics and the way that they're developing with cardiology. Do you work with cardiologists within your own clinics, or do you still refer across?
Well, I have a cardiologist who sits on our hospital's metabolic task force with us, Dr. Morgan. And so we've established a really nice relationship. And he has really become in tune to the fact that one of the biggest risk factors for cardiovascular disease is insulin resistance and metabolic syndrome, chronic inflammation, not just LDL. And so he understands now to focus on all of the metabolic issues and understands that in his patients, he needs to get those reversed to improve their cardiac outcomes. So he's really been a good referrer to us. And the flip side is, as part of our center, we order CT calcium scores on everyone with metabolic syndrome. I'm not sure if Spain has access to that technology, but for us, it's very economical and very accessible to get a CT coronary calcium score. And so we get that on everyone with metabolic syndrome. And we as gastroenterologists and have liver doctors diagnose a lot of cardiovascular disease. And so he gets referrals from us as well to help co-manage the patient that now has diagnosed cardiovascular disease.
Fantastic. And Dr. Lopez-Alper, do you use cardiology within your own clinic, or do you refer across?
Perfect.
In our clinic, not exactly in our clinic, we don't have a cardiologist. However, we have 3 cardiologists that we know, and that when we see patients that need to go there, we tell them we have these 3 cardiologists. Go see them and go see for their opinion also. So for an assessment, a continuous assessment with other specialists. And we also have a neurologist in the clinic that we do have. And regarding the CT scans, those we don't do in the private clinic. We don't do CT scans in the private clinic, as it is a very costly machine. And we, of course, it is not. However, in the public health system, it is very hard also to get sometimes CT scans, because the public health system sometimes is not as effective. It's in a crisis. Also, we don't have that access to CT scans as other countries may or can have. But yeah, we also work closely with cardiologists and the neurologists and other specialties. And with digestive. Digestive is very important also. We refer people to a digestive clinic that we closely work with.
On behalf of the surfers, our guests, and our sponsors, Regeneron Pharmaceuticals, LiverRight, and Talazun Health, thanks for joining us this week.
Please join us again next week when we share Louise's and Roger's choices for the big story of the first 6 months, plus an interview from The Vault, your favorite and most listened to from among our past year's episodes.
And until next week, stay safe, surf on, and we'll see you again on Surfing Next Tsunami Podcast. Bye-bye now.